Good morning. My name is Sameh Al-Zubiedi. I'm an associate professor of pharmacology and therapeutics at the School of Pharmacy, University of Jordan. Also, I'm a member of the ISOP Middle East Chapter Scientific Committee and the Medication Errors Specific Interest Group. Before I start my presentation, I would like to thank the International Society of Pharmacovigilance ISOP for giving me this opportunity to present on World Patient Safety Day. I will be presenting today on drug safety in pediatrics. I will focus on healthcare professional awareness and adverse drug reactions reporting in my country, Jordan. Before I start my presentation, I have to say that I have no relevant financial relationships to disclose, and all the views expressed in this presentation, they reflect my own personal views and they should not be attributed by any means to the International Society of Pharmacovigilance. Pediatrics is a special population. We should not look at pediatrics as small adults. They differ from adults in physiology and also in the pharmacokinetics and pharmacodynamics of the drugs. It is important to know that evidence on safety and effectiveness of drugs in pediatrics is limited or unavailable. This means that off-label drug use is common in this population. Also, over-the-counter traditional and herbal medicines are commonly used in pediatrics. Furthermore, abuse by teenagers with non-medical prescription of legal and illegal drugs happens quite often nowadays. During my presentation, I will focus on adverse drug reactions reported in the pediatric population. Again, pediatrics, they differ anatomically and physiologically from adults. Also, they exhibit differences in their pharmacokinetic and pharmacodynamic characteristics. When it comes to drugs that are used for the treatment of different diseases or conditions in pediatrics, I prefer to classify them into two main categories. The first category is the drugs that are used by both adults and pediatrics, and the second category are pediatric specific agents. I'm referring here to vaccines. Now, when it comes to the drugs that are used for both adults and pediatrics, it is important to remember that there are specific differences in the frequency and the type of adverse drug reaction seen in pediatrics compared to adults. For example, some of the adverse reactions could be specific to the pediatric population, like for example, growth suppression associated with long-term use of corticosteroids. Also, pediatrics sometimes can be exposed to adverse drug reaction of drugs that are used by the mother during pregnancy. And these adverse reaction could be short-term that appears shortly after the delivery. For example, the withdrawal of benzodiazepines, or some of them they can be long-term secondary ADRs which require longer time to appear. For example, some congenital malformation and some psychiatric complications associated with some drugs acting on the CNS like antidepressant. It is important to know that susceptibility to adverse drug reaction may change according to age, stage of growth and development, and the frequencies varies considerably within the pediatric population and from adults. It is important to remember, in general, that the frequency of ADR is higher in pediatrics than adults, taking into consideration the small proportion of pediatrics when compared to the adult in terms of the number of patients who are receiving the drug. Sometimes, for example, pediatrics, they lack the risk factors for some ADRs, for example, the kidney injury associated with non-steroidal anti-inflammatory agents. Also, it is important to highlight some of the practical issues that increase the likelihood of adverse drug reactions in the pediatrics. First of all is the weight-based dosing. It is a common practice that most of the drugs used for the treatment of pediatrics are dosed based on the weight. This will increase the likelihood of both overdosing and underdosing. Overdosing would increase the risk of adverse drug reaction. Underdosing would increase the risk of therapeutic failure. Also, it is important to remember that pediatrics as a population are heterogeneous and there are age-specific differences in their pharmacokinetics and pharmacodynamics. This means that the doses of the drugs, they require change as the child grows. Also, it is important to know that in some scenarios, we don't have an appropriate pediatric formulation, particularly for both oral and parenteral administration, which means in case of oral administration that we have to rely on the adult formulation. For example, we have to crush the tablet, prepare it in a proper vehicle of which we don't know whether the drug will remain stable, and we don't know exactly the bioavailability of drug in such a condition. Also, when it comes to parenteral formulation, sometimes a series of dilutional steps will mean that sometimes there will be errors in the preparation and in the calculation, which will likelihood increase the risk of medication errors in the pediatrics. Also, we have to know that there are some inappropriate packages and lack of awareness among parents and caregivers. It is also important to know that some conditions in the pediatrics would affect the risk of toxicity. For example, malnutrition and dehydration. For example, dehydration will increase the risk of ibuprofen-associated acute kidney injury in pediatrics. Also, cultural differences associated with misunderstanding of medicine instruction, and also we have to know that adolescents, which are a group of the pediatric population, may ingest medicine with suicidal intent or may experience health problem associated with the abuse of drugs. In my presentation, I will focus on the findings of one study in Jordan where we looked at the association between off-label drug use and adverse drug reactions in pediatrics. Off-label drug use is defined as the use of a registered medicine in a way that is not included in or approved by the regulatory body. As I said previously, globally, off-label drug use is common in the pediatric population. However, the prevalence of off-label drug use in pediatrics varies considerably depending on the age, country, and settings. We know that off-label is common in neonates and infants compared with children and adolescents. Also, it varies considerably depending on the terms of drug licensing from one country to another and from one setting to another. So, for example, in the neonatal ICU, it is estimated that almost 90% of the drugs that are used are off-label. Off-label is associated with high risk of ADRs and medication errors in the pediatrics. Previously, it has been estimated that off-label drug use is associated with 1/3 to 1/2 of adverse drug reaction occurring in pediatric hospitals. Also, off-label drug use is associated with 23% increase in the adverse drug reaction in pediatrics. However, the finding of these studies were basically based on data obtained from hospitalized settings. Therefore, we decided in Jordan to look at the association between off-label drug use and adverse event in Jordanian pediatric population using data obtained from spontaneous reports of adverse events in pediatrics as reported to the National Jordanian Pharmacovigilance Center between January 2013 and December 2015. Reports with missing age or events, ambiguous drug names, and duplicate reports were identified and excluded from the analysis. After that, each ICSR was assessed in order to define if each suspected drug was either authorized, off-label, or unknown, depending on the summary of product characteristics. The summary of product characteristics for each included agents were obtained from the Jordanian Food and Drug Administration. Also, we looked at the association between off-label drug use and the seriousness of the adverse event. According to this study, we defined a serious adverse event if it resulted in inpatient hospitalization or prolongation of existing hospitalization. A total of 845 adverse drug events reports in pediatrics between 2013 and 2015 were reported to the National Jordanian Pharmacovigilance Center. After excluding 64 reports, a total of 791 adverse drug event reports in pediatric population were included in the final analysis. The findings revealed that almost 2/3 of these reports were associated with off-label drug use. Collectively, anti-cancer, anti-infective agents, and immunosuppressants, they constitute around 90% of the adverse drug events in the Jordanian population. Also, our findings revealed that the highest proportion of off-label adverse events were observed in infants, followed by adolescents and children, and this was statistically significant. Also, with anti-cancer compared with other agents. Also, we looked at off-label drug use associated adverse drug events in Jordanian pediatric population and the seriousness of the adverse event. Again, as I said previously, a serious adverse event was defined as an event that leads to hospital admission or prolongation of hospitalization. Again, our findings revealed that 83% of hospital admissions were associated with off-label drug use, with the highest proportion observed with anti-cancer medication. Overall, we found that there is a 73% increase in the risk of hospitalization with off-label drug use being implicated in an adverse event compared with authorized medication. As you can notice with me, the vast majority of cases were associated with the use of anti-cancer drug. After excluding anti-cancer drugs from the analysis, the off-label drug use associated adverse event remains significantly associated with roughly 13% increase in the risk of hospitalization in comparison with licensed medication. It is important to highlight here that we did not perform a formal causality assessment between the suspected drug and the event. This was mainly depend on the quality of data that we obtained from the spontaneous report database. The finding of this study and other studies highlight the association between off-label drug use and adverse drug reaction in the pediatric population. Also, it highlights the association between off-label drug use and serious events in pediatrics. This means more studies are needed and more evidences are needed to assess the efficacy and safety of drugs in pediatric population, particularly when it comes to drugs with narrow therapeutic index like the anti-cancer medications. In the next part, I will be discussing the legitimate role of healthcare professional to drug safety in the pediatric population. Again, as we all know, healthcare professionals, they play a key role in the identification and reporting of ADRs and medication error. This contribution to the pharmacovigilance reporting system will improve the signal detectability in this population. Also, they are responsible for disseminating best practices measures to prevent ADRs and cultivate a culture safety within their practices. Also, they contribute to the prevention of adverse drug reaction as they are involved in the treatment processes, as well as their contribution to patient caregiver education. However, all these efforts are confronted by their knowledge, attitude, and practices toward pharmacovigilance and ADR reporting, which will affect both the quality and quantity of reports in pediatrics. Therefore, we decided in Jordan to assess the level of knowledge, attitude, and practices of Jordanian pediatrician and pediatric residents toward pharmacovigilance and ADR reporting using a structure-validated questionnaire which was distributed to 142 pediatricians working in 9 governmental, university, and private hospitals. I will take you now through some of the key findings of this study. First of all, only 25% of pediatricians have heard of PV before taking part in this study. A minority of them knew how to report ADR in the pediatric population. Despite having an excellent attitude toward ADR reporting and the importance of ADR reporting in pediatrics, only 29% of the participating pediatricians have really reported ADR for cases they noticed or encountered in their own practices. Among all the respondents, only 8.5% of them have claimed to complete an ADR report. Also, the findings of our study identified several barriers that prevents Jordanian pediatricians from participating effectively in the pharmacovigilance and ADR reporting system in the country. They were broadly classified into health system related barriers and barriers related to their knowledge and clinical competences. Therefore, these highlight the importance of training and education to pediatricians and healthcare professionals on the importance of pharmacovigilance and ADR reporting within their practices. Finally, strengthening the pediatric safety requires effective and efficient communication and networking between key drivers and stakeholders. This includes healthcare providers and their institutions, health system and drug regulators, pharmaceutical industry, research organization, and health technology. We can get benefit from new technologies in artificial intelligence, social media, and electronic medical records to increase the level of understanding and the level of knowledge regarding patient safety and drug safety in pediatrics. Thank you very much for your time.